Lemtrada, alemtuzumab, proposed mechanism of action. Multiple sclerosis, or MS, is an autoimmune disease characterized by inflammation of the central nervous system. This inflammation is believed to result in demyelination and axonal loss that can lead to the symptoms and disability associated with MS. In MS, both T and B cells are presumed to play a pivotal role and are key drivers thought to cause inflammation. Autoreactive T and B cells are thought to cause damage to the central nervous system in people with MS. Lemtrada is a monoclonal antibody that selectively binds to CD52, a cell surface antigen highly expressed on lymphocytes, T and B cells. The mechanism by which Lemtrada exerts its therapeutic effects in MS is unknown. By binding to CD52, Lemtrada depletes these cells from circulation in the periphery. Other immune cells in the periphery have lower CD52 expression and are minimally affected. Serum concentrations of Lemtrada were generally undetectable within approximately 30 days following each treatment course. T and B cells repopulate over time. This graph shows the white blood cell count following Lemtrada treatment courses. Lemtrada depletes circulating lymphocytes while innate immune cells, including eosinophils, neutrophils, basophils, and monocytes remained within normal range. After depletion of CD52-expressing T and B cells, these cells slowly repopulate over time. B cell counts usually reach baseline levels by 6 months, while T cells generally do not reach baseline levels by 12 months. Approximately 40% of patients had total lymphocyte counts reach normal levels 6 months after each course. 80% of patients reach normal levels after 12 months. The proportion of regulatory T cells was elevated following Lemtrada treatment, gradually returned toward baseline levels, but remained elevated at month 12. In summary, Lemtrada selectively binds to and depletes CD52-expressing T and B cells, two key drivers thought to cause MS inflammation. Lemtrada, alemtuzumab, important safety information. Indication: Lemtrada is indicated for the treatment of patients with relapsing forms of multiple sclerosis, MS. Because of its safety profile, the use of Lemtrada should generally be reserved for patients who have had an inadequate response to 2 or more drugs indicated for the treatment of MS. Important safety information. Warning: autoimmunity, infusion reactions, stroke, and malignancies. Lemtrada causes serious, sometimes fatal, autoimmune conditions such as immune thrombocytopenia and anti-glomerular basement membrane, anti-GBM disease. Monitor complete blood counts with differential serum creatinine levels and urinalysis with urine cell counts at periodic intervals for 48 months after the last dose of Lemtrada. Lemtrada causes serious and life-threatening infusion reactions. Lemtrada must be administered in a setting with appropriate equipment and personnel to manage anaphylaxis or serious infusion reactions. Monitor patients for 2 hours after each infusion. Make patients aware that serious infusion reactions can also occur after the 2-hour monitoring period. Serious and life-threatening stroke, including ischemic and hemorrhagic stroke, has been reported within 3 days of Lemtrada administration. Instruct patients to seek immediate medical attention if symptoms of stroke occur. Lemtrada may cause an increased risk of malignancies, including thyroid cancer, melanoma, and lymphoproliferative disorders. Perform baseline and yearly skin exams. Because of the risk of autoimmunity, infusion reactions, and malignancies, Lemtrada is available only through restricted distribution under a Risk Evaluation and Mitigation Strategy (REMS) program. Call 1-855-676-6326 to enroll in the Lemtrada REMS program. Contraindications. Lemtrada is contraindicated in patients who are infected with human immunodeficiency virus (HIV) because Lemtrada causes prolonged reductions of CD4+ lymphocyte counts. Warnings and precautions. Autoimmunity. Treatment with Lemtrada can result in the formation of autoantibodies and increase the risk of autoimmune-mediated conditions, including serious autoimmune conditions. Measure the urine protein to creatinine ratio prior to initiation of treatment. Obtain complete blood counts with differential serum creatinine levels and urinalysis with cell counts before starting treatment, and then monitor at monthly intervals until 48 months after the last dose of Lemtrada or longer if clinically indicated. Infusion reactions. Lemtrada causes cytokine release syndrome resulting in infusion reactions. In clinical studies, 92% of Lemtrada-treated patients experienced infusion reactions. Serious reactions occurred in 3% of these patients and included anaphylaxis in 2 patients, including anaphylactic shock, angioedema, bronchospasm, hypotension, chest pain, bradycardia, tachycardia, including atrial fibrillation, transient neurologic symptoms, hypertension, headache, pyrexia, and rash. In some patients, infusion reactions were reported more than 24 hours after Lemtrada infusion. Post-marketing cases of pulmonary alveolar hemorrhage have been reported with onset within 48 hours of Lemtrada infusion. Cases of severe, including fatal, neutropenia have been reported within 2 months of Lemtrada infusion. Mild to moderate decreases in platelet counts, starting at the time of alemtuzumab infusion, have been reported. Pre-medicate patients with corticosteroids immediately prior to Lemtrada infusion for the first 3 days of each treatment course. Consider pre-treatment with antihistamines and/or antipyretics. Infusion reactions may occur despite pre-treatment. Lemtrada can only be administered in certified healthcare settings that have on-site access to equipment and personnel trained to manage infusion reactions, including anaphylaxis and cardiac and respiratory emergencies. Stroke and cervicocephalic arterial dissection. In the post-marketing setting, serious and life-threatening stroke has been reported within 3 days of Lemtrada administration, with most cases occurring within 1 day. In the post-marketing setting, cases of cervicocephalic arterial dissection involving multiple arteries have been reported within 3 days of Lemtrada administration. Educate patients on the symptoms and instruct patients to seek immediate medical attention if symptoms of stroke or cervicocephalic arterial dissection occur. Malignancies. Lemtrada may cause an increased risk of malignancies including thyroid cancer, melanoma, and lymphoproliferative disorders. Monitor for symptoms of thyroid cancer. Perform baseline and yearly skin exams. Because Lemtrada is an immunomodulatory therapy, caution should be exercised in initiating Lemtrada in patients with pre-existing or ongoing malignancies. Lemtrada REMS program. Only prescribers, patients, pharmacies, and healthcare facilities certified and enrolled in the REMS program can prescribe, receive, dispense, or administer Lemtrada. Immune thrombocytopenia (ITP) occurred in 2% of Lemtrada-treated patients in clinical studies in MS. One Lemtrada-treated patient developed ITP, then went unrecognized prior to the implementation of monthly monitoring requirements, and died from an intracerebral hemorrhage. ITP has been diagnosed more than 3 years after the last Lemtrada dose. If ITP is confirmed, promptly initiate medical intervention. Glomerular nephropathies, including anti-GBM disease, occurred in 0.3% of Lemtrada-treated patients in MS clinical trials and have been diagnosed up to 40 months after the last dose of Lemtrada. In post-marketing cases, some Lemtrada-treated patients with anti-GBM disease developed end-stage renal disease requiring dialysis or renal transplantation. Urgent evaluation and treatment is required because early detection and treatment of nephropathies can improve the preservation of renal function and may decrease the risk of poor outcomes. Anti-GBM disease can be life-threatening if left untreated. Alveolar hemorrhage, manifested as hemoptysis, is a common component of anti-GBM disease and has been reported in post-marketing cases. Increased serum creatinine with hematuria or signs of pulmonary involvement of anti-GBM disease warrant immediate evaluation. Patients and caregivers should be instructed to seek medical advice if they have concerns. Thyroid endocrine disorders, including autoimmune thyroid disorders, occurred in 36.8% of Lemtrada-treated patients in MS clinical studies. Newly diagnosed thyroid disorders occurred throughout the uncontrolled clinical study follow-up period, more than 7 years after the first Lemtrada dose. Serious thyroid events occurred in 5.2% of patients and included cardiac and psychiatric events. In Lemtrada-treated patients, 3.8% underwent thyroidectomy. Thyroid disease poses special risks in women who are pregnant. In patients with an ongoing thyroid disorder, Lemtrada should be administered only if the potential benefit justifies the potential risks. Obtain thyroid function tests prior to initiation of treatment and every 3 months until 48 months after the last infusion or longer if clinically indicated. Other autoimmune cytopenias occurred in Lemtrada-treated patients in MS clinical trials, including neutropenia, hemolytic anemia, and pancytopenia. One Lemtrada-treated patient with autoimmune pancytopenia died from sepsis. Prompt medical intervention is indicated if a cytopenia is confirmed. Autoimmune hepatitis causing liver injury, including acute liver failure requiring transplant, has been reported in patients in the post-marketing setting. Obtain serum transaminases and total bilirubin levels prior to starting Lemtrada, periodically until 48 months after the last dose, and promptly upon patient developing signs or symptoms suggestive of hepatic dysfunction. Interrupt or discontinue treatment as appropriate. Infections occurred in 71% of Lemtrada-treated patients compared to 53% of patients treated with interferon beta-1a in clinical studies. Serious infections occurred in 3% of patients treated with Lemtrada as compared to 1% of patients treated with interferon beta-1a. Serious infections in the Lemtrada group included appendicitis, gastroenteritis, pneumonia, herpes zoster, and tooth infection. Do not administer live viral vaccines following a course of Lemtrada, as patients may be at increased risk of infection. Consider delaying Lemtrada administration in patients with active infection until the infection is fully controlled. Concomitant use of anti-neoplastic or immunosuppressive therapies could increase the risk of immunosuppression. In the post-marketing setting, serious, sometimes fatal, opportunistic infections have been reported, including aspergillosis, coccidioid mycosis, histoplasmosis, pneumocystis jirovecii pneumonia, nocardiosis, and cytomegalovirus infections. Listeria monocytogenes infections, including fatal cases of Listeria meningoencephalitis, have occurred in Lemtrada-treated patients. Listeria infections have occurred between 3 days to 8 months after taking Lemtrada. Advise patients to avoid or adequately heat foods that are potential sources for Listeria monocytogenes. Initiate these precautions prior to receiving Lemtrada. Advise patients to watch for symptoms of Listeria infection and seek prompt medical help if symptoms occur. Herpes viral infection developed in 16% of Lemtrada-treated patients compared to 3% of interferon beta-1a patients. Administer antiviral prophylaxis for herpetic viral infections starting on the first day of each treatment course and continue for a minimum of 2 months following treatment with Lemtrada or until CD4+ lymphocyte count is greater than or equal to 200 cells per microliter, whichever occurs later. Cervical human papillomavirus, HPV infection occurred in 2% of Lemtrada-treated patients. Annual screening is recommended for female patients. Active and latent tuberculosis cases occurred in 0.3% of Lemtrada-treated patients, most often in endemic regions. Fungal infections, especially oral and vaginal candidiasis, occurred in 12% of Lemtrada-treated patients compared to 3% of interferon beta-1a patients. Before initiating Lemtrada, consider screening patients at high risk of hepatitis B virus, HBV, and hepatitis C virus, HCV infection. Carriers of HBV and/or HCV who receive Lemtrada may be at risk of irreversible liver damage relative to a potential virus reactivation. Acute acalculous cholecystitis, AAC. Lemtrada may increase the risk of AAC, which occurred in 0.2% of Lemtrada-treated MS patients compared to 0% of patients treated with interferon beta-1a. Post-marketing cases of AAC have also been reported. Time to onset of symptoms range from less than 24 hours to 2 months after Lemtrada infusion. Typical risk or predisposing factors, such as concurrent critical illness, were often not reported. AAC is associated with high morbidity and mortality if not diagnosed early and treated. If AAC is suspected, evaluate and treat promptly. Pneumonitis, including hypersensitivity pneumonitis and pneumonitis with fibrosis, occurred in 0.5% of Lemtrada-treated patients in clinical studies. Cases of hypersensitivity pneumonitis and pneumonitis with fibrosis occurred in clinical studies. Advise patients to report symptoms of pneumonitis, e.g., shortness of breath, cough, wheezing, chest pain or tightness, and hemoptysis. Drug products with same active ingredient. Lemtrada contains the same active ingredient, alemtuzumab, found in Campath. If Lemtrada is considered for use in a patient who has previously received Campath, exercise increased vigilance for additive and long-lasting effects on the immune system. Most common adverse reactions. In controlled clinical trials, the most common adverse reactions, incidence greater than or equal to 10% and greater than interferon beta-1a, with Lemtrada versus interferon beta-1a were rash 53% versus 6%, headache 52% versus 23%, pyrexia 29% versus 9%, nasopharyngitis 25% versus 19%, nausea 21% versus 9%, urinary tract infection 19% versus 8%, fatigue 18% versus 13%, insomnia 16% versus 15%, upper respiratory tract infection 16% versus 13%, herpes viral infection 16% versus 3%, urticaria 16% versus 2%, pruritus 14% versus 2%, thyroid gland disorders 13% versus 3%, fungal infection 13% versus 4%, arthralgia 12% versus 9%, pain in extremity 12% versus 9%, back pain 12% versus 8%, diarrhea 12% versus 6%, sinusitis 11% versus 8%, oropharyngeal pain 11% versus 5%, paresthesia 10% versus 8%, dizziness 10% versus 5%, abdominal pain 10% versus 5%, flushing 10% versus 4%, and vomiting 10% versus 3%. Use in specific populations. Physicians are encouraged to register patients in the Pregnancy Exposure Registry by calling 1-866-758-2990. Antibodies, including anti-CD52 and autoantibodies, may be transferred from the mother to the fetus during pregnancy. Placental transfer of antithyroid antibodies resulting in neonatal Graves' disease has been reported. Safety and effectiveness in pediatric patients less than 17 years of age have not been established. Use of Lemtrada is not recommended in pediatric patients due to the risks of autoimmunity and infusion reactions, stroke, and because it may increase the risk of malignancies.